In the previous few videos, we have discussed extensively on the airway devices. In this particular section, we are going to discuss the fine aspects of endotracheal intubation. In the sense, we are going to be discussing on the intubation sequences, and among those intubation sequences, that one important intubation sequence, that is rapid sequence intubation, is what our target of learning in this particular video is. So first, before going into those intubation sequences, let us see the indications and the contraindications of endotracheal intubation. Even though you don't have that much contraindications, all of the contraindications which I'm going to tell are relative contraindications for endotracheal intubation. But let us see in detail what are the indications and contraindications. First thing, I'm going to discuss on the indications of endotracheal intubations. Indications wise, the first indication, there are three classic indications. In that, the first indication will be respiratory failure. We have a separate section of video on respiratory failure where it is defined as the PaO2 less than 60 millimeters of mercury. Go back to the respiratory failure section and learn if you have not already learned. Second, if the patient is having inadequate oxygenation or ventilation. So in respiratory failure and inadequate oxygenation or ventilation, you can try other ventilation techniques or oxygenation techniques. If they fail, definitely endotracheal intubation is an option. Number 3, airway protection. So often this is the most important and very neglected indication as well, that is airway protection. Because whenever the patient is not able to protect their own airways, for example, if they have a very low GCS, typically if they have less than 8, which forms the definition of coma as well. So in these patients who cannot protect their own airways, there is a lot of chances that they can aspirate and the lung may be damaged and they may die because of that. So ETT, yes, can give a good airway protection, especially when you are going to use a cuffed endotracheal tube. So when you inflate the cuff, they does provide a good airway protection and prevent aspiration to a great extent, at least in the acute stages. But if you use ETT for a long time, the cuff may form wrinkles and they are still prone for microaspiration. That is a different topic, but still they does provide a good airway protection, at least for the short run. So airway protection, very, very important. This is also one of the main reasons why during your surgeries, when you are giving general anesthesia, you are going to do a endotracheal intubation just to protect their airways. That is the main reason. All right. So these three are the principal and important indications for endotracheal intubation. But there are some rarer indications for endotracheal intubation also. So what are the rare indications? If the patient is having a raised intracranial pressure, raised ICP becomes a indication for endotracheal intubation for two reasons. One, they might be having a low GCS. That itself is an indication. So that's not the main thing here we are talking about, but in concern with the current topic. So what is more important is, whenever you have a raised ICP, you can do something called a therapeutic hyperventilation. Therapeutic hyperventilation. This is a very important concept because you know how hyperventilation is going to help these patients, because hyperventilation will wash out the carbon dioxide from the body and they will have a low PaCO2. This low PaCO2 definitely will reduce the cerebral blood flow, and reduction in the cerebral blood flow definitely will result in fall of the intracranial pressure. So this is how it works. But how much you are going to reduce the CO2 is the question. Remember, the normal PaCO2 is somewhere in the range of 36 to 44 millimeters of mercury. We know that. But in therapeutic hyperventilation, you have to keep the CO2 just in the range of 30 to 35 millimeters of mercury. This is the target PaCO2 when you are doing a therapeutic hyperventilation. This is again very important. You just keep it in the mild hypocapnic range. If you reduce to less than 30 millimeters of mercury, again, lot of trials have proven that is going to cause increased mortality. A lot of explanations are there for that, but still none of them are conclusive. But trials, every single one has proven that if you reduce the PaCO2 to a much lesser value, means you're going to result in high mortality. So don't do that. So this is going to be the target, and this can work only for a short time, and still you have to address the cause of raised ICP and you have to eliminate them. So then only the patient will be improving much better way. Okay. So this is the first rare indication for endotracheal intubation, that is raised ICP. The second rare indication is when the patient is having a lot of copious secretion in the respiratory tract or a lot of blood that is bleeding in the respiratory tract. So, and you can't remove them, and the patient can't remove them by cuffing, and you have a lot of problems in removing them, yes, endotracheal intubation does facilitate the removal of this secretions and blood from the respiratory tract. So these are some of the indications for endotracheal intubation. So let us move on to the contraindications. What are the contraindications? There are not any absolute contraindication for endotracheal intubation. You have to note that every single contraindication is relative only in its own sense. So the first contraindication I'd like to tell is if you have a significant upper airway pathology. Remember, endotracheal tube is something that passes through the upper airways and enters into the glottis and into the lower airways. So if you have a significant upper airway pathology like severe laryngeal edema, you have a severe epiglottitis, some severe injury to the oral cavity like road traffic accidents, the face is malformed. So this becomes relative indications. Yes, it becomes really difficult to pass the endotracheal tube into the glottis. So number two, if you are anticipating a difficult intubation, anticipating a difficult airway or a difficult intubation, you know that the things are going to be difficult and you can't see the insertion of the ETT into the glottis properly. So once again, it's a relative contraindication. In the anticipated difficult airway or difficult intubation, you can probably try other techniques like awake intubation or fiber optic bronchoscope mediated intubation. So you can try other techniques, but still you have a relative contraindication there. So apart from that, I don't think there are much contraindications for endotracheal intubation as such. Clear. So then let us move on to the sequences of endotracheal intubation. So what are the intubation sequences? Sequences wise, we have four classic sequences for endotracheal intubation. One is the traditional sequence intubation. Second one is the rapid sequence intubation. Third one is the delayed sequence intubation. And fourth one is the awake intubation. These are the four classic sequences we have. In that, let us compare and contrast what are the differences between each of them. Let us understand. So the first one is the traditional sequence intubation. So this traditional sequence intubation, you will be often seeing in many OTs, operation theatres, where the anesthetist will induce the patient slowly and aram se they will be slowly paralyzing the patient and they will take their own time. So there is no urgency there. Most of the elective surgeries are done under traditional sequence intubation only. So what do you mean by this traditional sequence intubation? Remember, there are few assumptions we are making in a traditional sequence intubation. First, we assume the patient is cooperative and the patient is awake before the intubation is done. So the patient is well awake and well cooperative. This is the first assumption we are going to do, and many elective surgeries, this is the case. The patient will be well aware of what they are going to be done inside the operation theatre and they will be awake only and they will be very cooperative. Assumption number one. Second assumption I'll tell you in some time. So what you're going to do to these patients, you're going to do something called a pre-oxygenation. So remember, this is a quintessential step for any intubation. Except in few cases of awake intubation, pre-oxygenation is not really necessary, but still this pre-oxygenation is a quintessential step for any intubation process and any intubation sequence, especially if you are supposed to give a paralytic agent and if you are going to expect an apneic period during intubation, definitely pre-oxygenation is mandatory. So how long you have to give? You have to give pre-oxygenation for a minimum of 3 minutes, even though some people give for 5 minutes. But there are a lot of studies which tell pre-oxygenation more than 3 minutes has no much benefit compared to 5 minutes. Clear? So just 3 minutes is more than enough most of the times. And you're going to give 100% oxygen to these patients. Fine. All right. So why you do pre-oxygenation? We have seen this extensively again in the pulmonary medicine PFT chapter. So where I have told you have FRC. FRC is the one that's going to maintain the gas exchange even during the apneic period. So during intubation, when you give a paralytic agent, patient stops breathing, and during that time where the patient is apneic to the time you secure the tube inside, there is some time gap where the patient will be completely apneic and the gas exchange in the lungs is completely dependent on the FRC. So it is not an infinite volume. It does have its limitations because it is a fixed volume for a particular patient and you have only 21% oxygen concentration, that is the atmospheric oxygen concentration that can maintain only for a short period of time. And if you saturate that FRC with 100% oxygen instead of 21% oxygen, you can actually maintain the gas exchange for a relatively longer time during the apneic period, which means the time to desaturation during an apneic period will increase. That is the idea of saturating the FRC with 100% oxygen. All right. So, but still, even if you give 100% oxygen, it will maintain for a longer time, but not for an infinite time. The patient is going to desaturate at some point of time because the FRC will start having lesser and lesser oxygen with time. So, but still, at least you can prolong the time to desaturation. So that's the idea of doing a pre-oxygenation in the first place, and one of the quintessential steps for any intubation is pre-oxygenation. Very, very important point. So once you have done the pre-oxygenation, the next step, you have to give the sedation to the patient. You have to calm down the patient, give a sedation. Obviously this is called an induction of anesthesia. Sedation in a traditional sequence intubation is typically a soup, which means what I'm trying to tell is you add a lot of elements to it. So a lot of agents will be added. That's what we call a sedative soup. So usually the anesthetist might add a ketamine, along with that they might add a fentanyl. So a lot of things they will keep adding it. So it's a sedative soup like thing. So unlike your rapid sequence intubation where you don't add a soup, instead you will add only one particular agent because it's very rapid and fast. Here you have a lot of time as per the understanding. So you can take some time. So you can give multiple agents and allow the patient to sleep. So now once the patient starts sleeping, the anesthetist will definitely do one very, very important process called bagging. So either the anesthetist will be doing this or the assistant to the anesthetist will be doing this bagging. So this is a hallmark. So this bagging after sedation or paralysis is hallmark of a traditional sequence intubation. So this again carries its own risks. Suppose if you are bagging the patient after a sedation or probably after a paralysis, so this is going to give one thing, that is positive pressure ventilation, because bagging is associated with the positive pressure in the respiratory tract. Since you are doing with a mask and you have not yet intubated the patient, this is going to cause gastric insufflation, and definitely that gastric insufflation will raise intragastric pressure. Because of the increased intragastric pressure, there is a high risk of reflux and aspiration. But remember, there is a condition if the patient is in full stomach. If the patient is in full stomach, definitely there is a increased aspiration risk for sure. But please understand the fact, and that is the reason why majority of the traditional sequence intubation is followed in the operation theatre for elective surgeries, and the patient will be kept in empty stomach. So remember, one important assumption you have to make, it's not an assumption, you have to be very sure before doing a traditional sequence intubation and doing this bagging after sedation probably, definitely the patient should be in empty stomach. If the patient is in full stomach, you avoid this traditional sequence intubation and do not touch the bag usually after the sedation or paralysis. Definitely not done. So in a traditional sequence intubation, this is classic and a hallmark. Fine. So that is why we do this process in a elective surgeries where the patient will be nil per oral in the previous night and they will come to the OT in empty stomach. So once the sedation is done, you are going to start the paralytic agent and induce the paralysis. So once you give the paralysis, the patient will be relaxed and the anesthetist now is going to intubate the patient. This is a classic traditional sequence intubation. Now, move on to the rapid sequence intubation, RSI. Rapid sequence intubation has some differences, but remember, it is done in emergency scenarios. Here you don't have time. You want to have a quick control of the airway, which means you need to have a very quick control of the airway and you have to achieve this airway control in a short span of time. That's what we call it as rapid sequence intubation. And more than that, rapid sequence intubation assumes one important thing, that the patient is always in full stomach. I told you in full stomach, you can't touch the bag after your sedation and paralysis. Clear? So if the patient is in a full stomach, so you cannot do a traditional sequence intubation in a full stomach. So you have to do a RSI only. So what are the ideas that are proposed in RSI, rapid sequence intubation, when you are doing the intubation in emergency and you take an assumption that the patient is in full stomach by default? Because when the patient is coming with a head injury due to an RTA, to an emergency and or casualty, you have no idea whether the patient is in full stomach or empty stomach. You have to assume that the patient is full stomach in that case, and you have to do the rapid sequence intubation only. So what is the idea here? So obviously they will do the pre-ox. There's no doubt about that. So once you have done the pre-oxygenation, the emergency physician or critical care physician is going to sedate and paralyze the patient at a single shot. Sedation and paralysis in a single bolus. You don't have time here to wait slowly to give a sedation followed by a paralysis. you're going to give a shot. That's all. One single shot at sedation and paralysis. Once the patient is paralyzed, sleeps paralyzed simultaneously, you're going to put the tube in, intubate the patient. This is the idea. Remember, again, you can do the pre-oxygenation typically for 3 minutes. But remember, it's not just 3 minutes. There are some other definitions of how long you will give pre-oxygenation also. Alternatively, you can give for, you can give amount of air to the patient that is equivalent to 8 vital capacity. Clear? So you can give the breaths and the volume that is equivalent to 8 vital capacity. I can write here also either 3 minutes or an amount equivalent to 8 vital capacity breaths. Clear? So this is the idea of pre-oxygenation. So here there are two important differences are there. One, you don't bag. Definitely you never ever bag after a sedation paralysis unnecessarily. Suppose in very rare scenarios where you can't really intubate the patient, but you have given a sedation paralysis, but it is a failed intubation. In that condition, without any choice, you can bag the patient because you have to provide oxygenation to the patient. But otherwise, in a routine rapid sequence intubation, you never ever bag the patient after sedation and the paralysis. So this is one important point. So number one, that is a difference from traditional sequence intubation. Second one, you give sedation and paralysis in a single shot. You don't do sequential sedation and paralysis. You give sedation and paralysis in a single shot. This is also one of the quintessential components of rapid sequence intubation. And one more thing that is proposed is the fact that throughout the rapid sequence intubation, till you put the tube in place, you can maintain the cricoid pressure. You can do something called a cricoid pressure and you can maintain that. You know why you do a cricoid pressure? This giving cricoid pressure during rapid sequence intubation is also referred to as a Sellick's maneuver. So remember, in a traditional sequence intubation, this is unnecessary because the patient is in empty stomach. But in a rapid sequence intubation, you assume the patient to be in full stomach and inherently they are prone for aspiration of the gastric contents. So you just give a cricoid pressure. So when you compress the cricoid, this trachea, by compressing the cricoid, will go back posteriorly and they are going to compress the esophagus. To an extent, it provides the protection from the reflux of the gastric contents. That is the idea. But this is very, very important for rapid sequence intubation, but not for traditional sequence intubation. But again, there are a lot of conflicting data against this cricoid pressure and Sellick's maneuver because there are some trials tell that these are useful. There are some trials that tell these are not useful. In fact, there are some trials which tell they are harmful as well. For example, there is a trial which proved that giving cricoid pressure routinely did not have any benefit. In fact, they caused more desaturation because when you are pressing the cricoid, you are obstructing the airways, right? So once you are obstructing the airways means you have very high resistance to your intubation as well as your oxygenation, bagging, everything you have a high resistance. So that's why they feel that that cricoid pressure may be more dangerous than protective, but still the current idea is very, very controversial whether to use routinely cricoid pressure or not. But even though many of the Indian practitioners, yes, in emergency and in ICUs, when they are doing a rapid sequence intubation, yes, they does this cricoid pressure as well. Clear? So this is the classic rapid sequence intubation. So this is the difference. Now we are going to the third sequence of intubation, that is delayed sequence intubation. So where will you follow this delayed sequence intubation? Typically, you are going to do this when the patient is extremely agitated. When the patient is extremely agitated. This is where you are going to do the delayed sequence intubation. So in the sense, what is the problem in an agitated patient? So whenever the patient is agitated, one thing will happen for sure, that he will not let you touch the pre-oxygenation mask. So the pre-oxygenation is going to be extremely difficult in this patient, which means I told you this is a very, very important component of any sequence of intubation if you're planning to paralyze and deeply sedate the patient. So here the sequence will be little bit reversed so that the situation will be conducive for the pre-oxygenation. That's what you're trying to do. So what I'm going to do is, here I'm going to sedate the patient first. Clear? So with a dissociative anesthetic like ketamine. So sedate the patient like ketamine at a dose of, if they ask you dissociated dose of ketamine, it is 1 to 1.5 milligram per kilogram. You give ketamine, sedate the patient, which means now the patient will sleep and you are calming down the patient. Once the patient is calmed down, you do the pre-ox now. So the idea of DSI is very simple. It's a modified RSI where you give sedation first in order to do pre-oxygenation in an agitated patient. So that's it, very simple. In a single line, you can tell what is a DSI. So once you have pre-oxygenated the patient adequately, that is 3 minutes or amount of volume equivalent to 8 vital capacity breaths, now you're going to paralyze the patient. So once the paralysis is done, you can intubate the patient as well. So very simple, easy and PC, that's all. So remember, this is the delayed sequence intubation, all right, but it is not a must. You should always follow this sequence. Sometimes after giving pre-oxygenation and sedation, the patient might get a lot better, which means patient might improve a lot. So if the patient improves a lot, patient gets a lot better, no need to intubate at all. You can even abort the procedure. Abort the intubation. That is not called delayed sequence intubation, but still you can, it's not a must that you have to definitely intubate this patient. You can just abort the process and just observe the patient for some more time. Intubation is something like a tough process and it's tough for the patient and the family as well as the doctor as well. So just wait. So don't unnecessarily intubate. So, but this sequence is what we refer to as a delayed sequence intubation, where you are sedating the patient to do the pre-oxygenation in an agitated patient. That's it. Okay. The final sequence of intubation will be an awake sequence or an awake intubation. This is not usually given in some books as a sequence of intubation, as a separate type of intubation they have given, but still let us understand it as a particular sequence itself. So, what is the real thing in awake intubation? But really it's a misnomer. The name should not be called as awake, but instead, it will be falsely giving an idea that the patient will be awake and you are intubating them. No, it's not like that. So here the patient will be having light sedation. Still the patient will be sleeping, but you are just giving a light sedation. But the most important fact is the thing that you are not going to paralyze the patient at any cost. So why? Because the indication for awake intubation is anticipated difficult airway. Anticipated difficult intubation or anticipated difficult airway, you are not going to touch the paralytic agent at all. Very, very important. Clear? So why you are not touching the paralytic agent here? Why you are giving only light sedation? Remember, if you are giving deep sedation, the paralysis, and if you are not able to intubate the patient because you have already anticipated a difficult intubation, you are in a soup, and it's a nightmare for any physician as well as the patient and the attenders. Everyone, it's a nightmare. You can't intubate, but the patient isn't, paralysis is not taking any breaths at all. So to avoid all the potential complications because of patient not breathing, and you cannot put, you're anticipating that it's difficult to put the tube in. So you try to avoid that apneic period and you make sure that the patient is taking spontaneous breathing by giving light sedation without a paralysis. Clear? So here, what I am going to do is give just a light sedation and no paralysis. Make sure that the patient is taking spontaneous breaths so that in the event of cannot put the tube in, you can still manage the patient because the patient is taking spontaneous breathing. So now you can intubate the patient. Just intubating under light sedation, that's all. This is, that's what I've been beating around the bush for some time. So, intubating under light sedation is what we call awake intubation. Fine, all right. But optionally, you can give some pre-meds. Pre-meds in the sense pre-medications, especially in when you are doing an awake intubation, because when you are manipulating the oropharyngeal area, because you want to intubate, you might result in a lot of secretions pouring out. So you have to avoid that because that's going to create a very bad area in that region. So it's not a good sight, isn't it? For any critical care patient, the secretions are a nightmare most of the times. So you're going to give pre-meds that can reduce the secretions as well as anesthetize the tract, because if you are not having any local anesthesia, it induces a lot of, because there will be some pain, there will be some local stimulation of the sensory system, so that will itself create a sympathetic discharges from the patient, and that might result in a lot of other complications as well. So first reduce the secretions by giving anticholinergic drugs like glycopyrrolate or atropine, even though we prefer glycopyrrolate in this scenario. And you can give a local anesthetic also in that area. Typically we prefer a lignocaine local spray or lignocaine jelly. Jelly is very poor, but local sprays are good, and nebulization of lignocaine is also good. Even some practitioners give injections of lignocaine everywhere in the airway also. So fine, so these are things you are going to do. So this is an optional thing, fine. So for doing a awake intubation, the best instrument that you can use is a fiber optic scope. Fiber optic scope is one of the best things that you can do during a awake intubation. But even though video laryngoscopy or direct laryngoscopy is used by most of the practitioners, because when you don't have a fiber optic scope in my hospital tertiary care center, I have to go for video laryngoscopy or direct laryngoscopy only. But still the best is always a fiber optic scope for awake intubations. So clear. So this is what are the different sequences of intubation. In this particular idea is to know about the rapid sequence intubation in detail. So let us dissect the rapid sequence intubation in detail. So because this is what is important for any critical care or emergency physician. Clear? So what is an RSI? So rapid sequence intubation. Please note the fact that it has 7 P's. It has 7 steps. Even though I told in a very short detail, because that's only an overview, but you have classic 7 P's in a rapid sequence intubation. What are the 7 P's? So it starts from preparation to your post-intubation management. So let us start with the first P, that is at time 0. Let us put a timeline. So I'm putting a time 0 first. That is the point where really the RSI starts. But remember, after this you have some steps in RSI. Before this time 0 also you have some steps in RSI. So that time 0 is your time. So that is where you induce and paralyze the patient, which means the first P, paralysis with induction, because in RSI you're going to do both at the same time. So this is the first P, paralysis with induction. As I told you, you have timeline after this paralysis and induction also, after this time 0, and you have timeline before this paralysis and induction as well. Clear? So let us start before first. So the time where the first step starts is T minus 10 minutes, which means you are going to begin 10 minutes before the induction paralysis, that is T minus 10. So that time you are going to prepare yourself. First is the preparation, first P. So what are the things you have to prepare yourself for? So that can be given by a acronym or a mnemonic called STOPMAID. So this will understand you to know what are things that are needed, in the preparation period. First one is the suction. Trust me, this is the usual thing that sucks most of the time, the suction. That's the one thing that really screws you to the core, because sometimes suction may not work or suction may not be prepared, it will not be available. So a lot of problems. So make sure that suction is available. And T stands for the tools. A lot of tools are there. You have the direct laryngoscopy blades or fiber optic scope, whatever things you need for intubation, the ET tube kit, then your ambu bags, many things are there. The tools are necessary. Gloves and O2 oxygen, O for oxygen. Definitely. That's a no-brainer. P stands for positioning tools. Now, like you need sniffing position, isn't it? For that, you need to put the pillow or towel under the head to make the patient is in sniffing position. So definitely yes, you need them. M stands for monitors. Obviously yes. A stands for assistance. Intubation is not a single man procedure. You need a lot of people around. So assistance and ambu. And I stands for IV line. No brainer again. Otherwise you can't give the drugs. And D stands for the drugs. Sedating agents like ketamine or propofol, whatever you prefer. And your neuromuscular blockers. The typical neuromuscular blocker of choice here is scolin, SUX. Okay. The second step. Second step is one of the most important steps. That is nothing but the pre-oxygenation. Clear? So when will you start the pre-oxygenation? What is the time you are going to start the pre-oxygenation? So let me tell T minus 5 minutes. Remember, before 5 minutes of induction paralysis, I am going to start the pre-oxygenation. So pre-ox. I told you are going to give the pre-ox for 3 minutes or at least volume equivalent to 8 vital capacity breaths. Okay, you have given the pre-ox. What are the ways to give the pre-oxygenation? So there are some ways depending on the patient profile. Let us assume the first patient, which is the most common type, where the patient will be extremely cooperative. At the same time, patient will be having adequate and spontaneous ventilation. Patient will be having adequate and spontaneous ventilation and is extremely cooperative as well. So in this particular scenario, you will be using NRBM. NRBM is a non-rebreather mask. So you have a separate section on oxygen delivery devices. So don't worry about these technical terms right now. NRBM is what we are going to use, non-rebreather mask, where oxygen will be flowed at flush rates. The flow of oxygen will be at flush rates. You might be asking me, what is flush rate? It is the maximum oxygen flow that is coming from particular central line in your particular hospital. Remember, you remove all the instruments. I'm not talking about the oxygen gauge that you are using. I don't want all those things, that thing that is connected with the water, and remove everything. Just connect directly to your central oxygen supply. Open the oxygen maximally. That is what we call flush rate. The maximum flow that can be given by any tertiary center from the central line. So usually flush rates are approximately 40 to 70 liters per minute. These are the usual flush rates. But even though some hospitals give it a lower flush rates, some hospitals give up to 105 liters per minute flush rate also. But this is the usual flush rate in majority of the hospitals. Okay, so this is number one. So how you are going to do in a cooperative patient with the adequate and spontaneous ventilation. Second condition, what if the patient is still cooperative, but is not having adequate but inadequate spontaneous ventilation? Inadequate and spontaneous ventilation, which means he's not taking sufficient breaths. He's having hypoventilation. He's taking shallow breaths. So you have to support that shallow breaths. Otherwise, you cannot pre-oxygenate adequately again. So to support that shallow breaths to full breath, you need to bag the patient. So we will be doing bag valve mask ventilation with or without PEEP, but BVM is mandatory here. Wait. You might ask me one question, sir, you told that BVM should not be done in rapid sequence. I told you after sedation paralysis, you don't do it unless and until it's needed. But before the sedation paralysis, yes, in these exceptional scenarios, you have to do the BVM, even if you're following a rapid sequence intubation. But you know, doing a BVM in a rapid sequence intubation is going to have a high risk of aspiration because of gastric insufflation. So do it very delicately and do it very meticulously. In the sense, you have to keep the insufflation pressures or inspiratory pressures, the peak pressures, to less than 20 centimeters of water, because many ambu bags now come with this gauge attached. So make sure that you don't press very hard, because to avoid the gastric insufflation. So whenever you are doing a BVM, definitely in this condition, I will prefer doing a cricoid pressure for sure. I will be preferring to do a cricoid pressure as well. But make sure you do it very, very delicately. Don't do it harder, because otherwise you will be resulting in gastric insufflation and aspiration. Okay. At the same time, make sure that the bagging you are doing is in sync with the patient's breathing, because here the patient is actually breathing. So make sure that the breathing is in sync with the patient's respiration. All right. Next, O2 flow. Again, you will be using the flush rates. That's really important. You have to give the maximum O2 flow to the patient at this point. Okay. Condition number 3. So what if the patient is having intrapulmonary shunting? So again, this is one thing that we have discussed extensively in the respiratory failure section. Intrapulmonary shunting, where VQ will be equal to 0, where there is no ventilation to an alveoli, complete alveolar collapse at certain places. So the right side alveolar directly goes to the left side, causing severe hypoxemia. Best example for this is ARDS. So where there will be a lot of areas where alveoli are collapsed. So in this condition, you cannot pre-oxygenate adequately unless until you open up this alveoli and give a positive pressure ventilation. So there are options for pre-oxygenation here. You can do a bagging, but definitely here the PEEP valve is mandatory. You have to attach a PEEP valve and give a good positive pressure ventilation to open up the alveoli. Then only there will be adequate pre-oxygenation in this scenario. Second, you can use NIV also for this sake, like CPAP or a BPAP. Third possibility, you can use a high flow nasal cannula, HFNC. I'll tell you how HFNC provides positive pressure to an extent. So we are having a separate topic on oxygen delivery devices. HFNC is a very important, and it's something like high regards now in the current pulmonology practice, especially in the critical care. High flow nasal cannula. So these are the ways, and obviously oxygen will be at flush rates. maximum rates, especially when you're using a BVM or a HFNC. Clear? So this is what you're going to do, right? So these are the things you're going to follow if the patient is having intrapulmonary shunting. Finally, number 4, what if the patient is uncooperative? So here the idea is very simple. If the patient is uncooperative, you are not going to follow the classic RSI. Instead, you shift the protocol to DSI. That's all. Here it's no longer an RSI. Even though it looks like it's an RSI, but here no longer you give an RSI. Instead, you give a DSI only. Delayed sequence intubation. Fine. So now you know how to do a pre-oxygenation. All right. Now, the next step will be pre-medications. Even though this is given by multiple different names, so pre-medications are generally given 3 minutes before the induction and paralysis. That is T-3. So right now this pre-medications is a term that is obsolete, trust me, but instead many books will give you pre-intubation optimization. That's what they're going to give, but whatever may be the case, pre-medications. But the idea is currently changing. The pre-intubation optimization means you expect some patients to go for hypotension after the intubation. You expect some patients to go for hypoxemia after the intubation. But I don't want to go into that great extreme details, but still pre-meds. So what are the traditional historical pre-meds that you're planning to use? So let us see the first one, that is fentanyl. Very, very important pre-med. Second pre-med is lignocaine. All these are IV medicines. I'm not talking about a local lignocaine sprays. IV lignocaine. And third one is the atropine. Even though, remember, the pre-meds are only highly optional. You do not do pre-meds in all the cases. For example, modern guidelines insert giving a push dose vasopressor. If you are anticipating a post-intubation hypotension, you can even give a push dose vasopressor under selective scenarios. Even before starting the intubation, you can give a phenylephrine 100 microgram shot. Clear? So anyway, that's a extremely big concept, so I'm not going to discuss in detail. So let us go to the pre-meds, traditional, historical pre-meds. Fentanyl. What is the dose of fentanyl? Usually 2 to 3 micrograms per kilogram. This is the usual dose of fentanyl. And where all you will give fentanyl? Indications whenever the patient is anticipated or having a high ICP like head injury patients, or if the patient is having a cardiovascular disease. So in this scenario, fentanyl will help you to reduce the sympathetic discharges in the body, blunt the sympathetic response. So that's why fentanyl is going to work. That's where it's going to work. So it's going to blunt the sympathetic response, so which is very, very important in these patients. So this is how fentanyl works. Fine. So let us move on to the lignocaine. IV lignocaine, usual dose is 1 to 1.5 milligram per kilogram. Standard dose is 100 milligram of lignocaine. Why you do that? Indication, you can use this lignocaine possibly in a patient with a raised ICP, because lignocaine is going to combat against further rise in the ICP. That's why. Finally, atropine, very, very rarely use medication in adults. We don't use it at all in the first place, but it can be used in certain children, especially if they are less than 1 year of age, that is the infants, because they are prone for post-intubation bradycardia. To avoid that complication, we are giving atropine as a pre-medication. But this is something, a lot of things. Pre-medication, these pre-medications may include a fast IV bolus of normal saline if you expect a post-intubation hypotension due to hypovolemia. You can give a push dose vasopressor in patients with sepsis. A lot of other things are also there in the sandwich, but right now we are not going to discuss in this particular video because it's beyond the scope of the current discussion. Okay, now your time has come. What's your time? Your paralysis and induction. So here you're going to use a lot of drugs. Really a lot of drugs is going to be used here. So what are the drugs? And let us see some of the properties. I'm not going to discuss about the core anesthetic properties of this drug, but still I need some properties to be known because you are going to practice this. And definitely all these are questions in exam. First one is the etomidate. The dose of etomidate is generally 0.3 milligram per kilogram. It's an ideal RSI drug because the onset, let me put O, onset of action is within 10 to 15 seconds, which is very ideal for an RSI drug, which means in RSI you expect a fast onset because there is no time. You want to do it very fast. So duration, Again, it's very short. Again, it's ideal for RSI because the patient need not be sedated once the patient is intubated. After intubation, sedation can be continued with many modern drugs like dexmedetomidine, but still, I don't want to give etomidate continuously. So the patient want to come out of etomidate related sedation fast. So that's again ideal. Offset is within 4 to 10 minutes. The duration will be only 4 to 10 minutes. But it's a very good RSI drug. So if you ask me, I will tell you, and the books also will agree with that it is the drug of choice for any rapid sequence intubation. And especially if the patient is in cardiogenic shock, this becomes the drug of choice. But note the point, whenever the examiner gives you shock and RSI, see whether the patient is in cardiogenic shock or non-cardiogenic shock. Cardiogenic shock, definitely etomidate. Non-cardiogenic shock, best answer will be ketamine, because ketamine raises the BP and the heart rate. But remember, increase in BP and heart rate in a cardiogenic shock may not be good for the patient. So that's why in cardiogenic shock, we prefer etomidate. And one reason why we prefer etomidate in this RSI and in patients with cardiogenic shock is the fact that etomidate is hemodynamically neutral. It doesn't cause any increase or decrease in BP. It doesn't cause any increase or decrease in the heart rate. It's pakka hemodynamically neutral. That's why we prefer this drug in these scenarios. But one problem is there, one important side effect of this drug, it can reduce the glucocorticoid synthesis, which means it can reduce the cortisol synthesis from the adrenal gland, which means they can result in post-intubation adrenal insufficiency. So if you're doing in the emergency, when they go to ICU, they might experience this post-intubation adrenal insufficiency, where the patient may not pick up the BP after that. So that is also one reason. In sepsis and septic shock, because of the same reason in sepsis and septic shock, I'm not telling this drug is contraindicated. Still, you can use etomidate for this purpose, but in these conditions, the ideal drug will be ketamine. Because in sepsis, already patient will have suppressed glucocorticoid synthesis. That's why in refractory septic shock, when they're not responding to vasopressors and IV fluids, we give hydrocortisone as an empirical therapy, 50 mg QID. That's the usual dose. Septic shock, all right. Shock, apart from cardiogenic shock, best is ketamine. But again, this ketamine doesn't interfere with the cortisol synthesis. That's the reason why in this condition we are giving ketamine. So if you have given etomidate in a patient with sepsis because you didn't have any other option, so you have to inform the ICU. Or if you have done an ICU, means you have to inform the next round doctor, because they might be giving a glucocorticoid, hydrocortisone shot, in case if the patient doesn't pick up the BP after that. So it's not contraindicated, but still a preferable drug is ketamine in this case. Okay. Number 2, ketamine. Second is ketamine. The standard dose of ketamine is 1 to 2 milligrams per kilogram. It's a dissociative anesthetic at this dose. The onset of action is approximately 45 to 60 seconds, a little bit slower onset, but still good. So duration of action is 10 to 20 minutes, still good enough for a faster offset. And usually we prefer ketamine if the patient is agitated. If the patient is agitated, prefer ketamine because it's going to calm down the patient, dissociative anesthetic, without causing any hemodynamic consequences. It has some hemodynamic consequences. So what are the hemodynamic consequences? Properties of ketamine. They are going to increase the BP, they are going to increase the heart rate, they are going to increase the intracranial pressure as well. They are going to cause bronchodilation. So these are the 4 important properties of ketamine that you have to know. So for this reason, that it causes increase in the BP and the heart rate, they can increase the mean arterial pressure because of the same reason. That's the reason why it is preferred in every single type of shock. It is preferred. I'm not telling again the choice, but it's preferred in a patient with shock. But remember, except cardiogenic shock, where etomidate becomes a drug of choice, because in cardiogenic shock, you need not have this high BP and high heart rate, not indicated. So for the same reason, avoid ketamine in patients who are having normal or elevated BP. In hypertensive patients, definitely it's a no-brainer. We are not going to use. Avoid. And also for the same reason that it causes raised ICP, it is absolutely contraindicated in patients with raised ICP. Definitely, you can't give. Especially in a patient with head injury, dare touch the ketamine. Don't do it. bronchodilation. Number 4. So that is the reason it's the preferred drug in reactive airways disease as well, like COPD, bronchial asthma, it's preferred. You can use etomidate as well, but it's not the first choice. Ketamine becomes the first choice there. Okay. These are some of the properties of ketamine, and this is how you prefer and in what stages you're going to prefer ketamine, I told you. At the same time, please avoid ketamine in cardiovascular disease as well for the same reason, that it raises the BP and the heart rate. Avoid in patients with cardiovascular disease. That's the reason we avoid this in cardiogenic shock as well. Clear? So these are some of the important points about ketamine that you have to know. Drug number 3, Midas, midazolam. You know, ketamine is a phencyclidine or phenylcyclidine. That's the class of drug that ketamine comes under. You know, midazolam is going to come under a class called benzodiazepine. All right? Fine. So, what is the dose of midazolam? Usually we give 0.1 to 0.3 milligram per kilogram. So this is the standard dose of midas. You can remember it's similar to that of etomidate, but generally we prefer a dose of 0.3 most of the time because midazolam is underdosed. So that is the reason why a lot of anesthetic textbooks give it has a very highly variable response, midazolam. So that is the reason why it is not routinely preferred for RSI. In fact, we don't prefer at all unless and until we have any other option. We don't prefer this midazolam. But because of the fact it's underdosed most of the times, at the same time, it produces a very variable response in the patient. It may not induce the patient properly. So this is the dose. What is the onset? Onset, once again, it is somewhere around 45 to 90 seconds or 60 to 90 seconds. This is the onset period of midazolam. Then you have duration, offset also, approximately 15 to 30 minutes, little longer, but okay, still good enough. But why we don't prefer is the reason behind that is the variable response. That's it, nothing else. But one good property about this benzodiazepine is they are amnestic. They produce amnestic effects, which is really good. That's also one reason why many anesthetists inside the OT off-label they use midazolam for many reasons, because they don't want the patient to remember the traumatic events, amnesia. Cool. But the one real danger is they can produce myocardial depression and they can also produce respiratory depression, both of which are dose dependent, which means they can produce hemodynamic instability and they can produce bradypnea and further fall in saturation as well. So you have to be very careful about that. So these are some of the properties of midazolam as a RSI drug. Number 4, propofol. Propofol is once upon a time used as a very, very common RSI drug. Before we had accumulated evidences for etomidate, propofol is a very good drug before that. So, but still, there are some problems with propofol. So, let us see what is propofol. Propofol is an alkyl phenol. And the dose of propofol is 1 to 3 milligram per kilogram. Usually, we give a 100 to 150 milligram dose generally. And you know the propofol contains egg as a preservative, and once opened, it should be used within 6 hours. It is milky white in color. We know all this. So, not a problem. Okay. So, what is the onset and offset? Onset is again very fast in 15 to 45 seconds, which is very, very good. And again, the duration is again very short, ideal RSI drug with respect to the timelines. But still, there is some problems with propofol. What is the problem? It causes dose-dependent hypotension, which means in hemodynamically unstable patients, please don't use this. They can crash the patient. So, do not use in hemodynamically unstable patients, which means the hypotension is typically dose-dependent. But one good thing, you have to see the good side of propofol also, they can cause bronchodilation. So for the same reason, it can be preferred as an RSI drug in patients with reactive airways disease. But remember, it's only the second choice or third choice. You don't use it as a first choice because first choice is always ketamine for reactive airways disease. At the same time, propofol can be preferred in patients who are having status epilepticus. There is no absolute contraindication for propofol. Relative contraindication is hemodynamic instability, but there is no absolute contraindication. And you can prefer this drug in patients with status epilepticus as well because it can suppress the seizures also. Apart from inducing the patient into anesthesia. Use propofol as a last resort. In status epilepticus protocol, if the seizures cross 30 minutes, you induce GA and intubate the patient. For induction with a general anesthetic, you can use propofol, midazolam, many drugs are there where you can use. Fine. But remember, propofol cannot be infused for a long time because it's going to result in propofol infusion syndrome, and green colored urine is a sign that you're giving too much propofol sometimes. Okay. Number 5, thiopentone. Thiopentone is a barbiturate. It's an ultra short acting barbiturate, previously referred to as truth serum because it's used by FBI, CBI to extract truth from the enemies, from the captivated prisoners. So it's also called as a truth serum often. So what is the duration of action of propofol and thiopentone, and what is the onset? Onset, again, it's a good RSI drug. Onset is within 30 seconds and the duration offset is within 5 to 10 minutes, which is the ideal RSI drug according to the timeline. But the problem is the side effects it's going to create. The side effect it's going to cause is hypotension. And again, it's dose dependent. And that is the reason why it's relatively contraindicated in patients with hemodynamic instability. Why it's going to cause hypotension? Because they are very powerful venodilators. It reduces the cardiac preload and they can reduce the BP. At the same time, they are going to also act as a myocardial suppression, which is again dose dependent. Again, these are the two main reasons why you are going to result in hypotension. So do not use this drug in hemodynamic instability. It's a very rarely used RSI drug, in fact. We don't have it in the emergency most of the times. Okay. Second, it can cause bronchoconstriction. Yes, absolutely right. It can result in bronchoconstriction, which means definitely do not use in reactive airways disease. Because why bronchoconstriction? Because they can produce histamine release. So never ever touch this drug in reactive airways disease. Never a choice. Okay. At the same time, since this drug being a barbiturate, it can induce the hepatic enzymes and they can precipitate an acute attack of porphyria. Especially in those suffering from acute intermittent porphyria, this drug should be avoided. They can precipitate or exacerbate porphyric attacks. Fine. Now see the good side. Good side, it is cerebroprotective and a natural anticonvulsant. So which means it can be used as a second or third choice drug in patients who are suffering from status epilepticus. So probably a choice, but not as a first choice, definitely. Okay. So these are the different induction agents you are going to use in an RSI. But remember, the choice is always between etomirate versus ketamine right now. Whether you use etomirate or ketamine. Rarely propofol. That's it. Choice is over. Done. Midazolam is exceptionally rare scenarios. Thiopentone, we don't use it at all. The next entity we are going to discuss is on the neuromuscular blockers. Remember, there are two neuromuscular blockers that we had now. One is the succinylcholine and second is the rocuronium, which is very commonly used in your rapid sequence intubation. Remember that succinylcholine is the choice, neuromuscular blocker of choice in almost every single RSI patient unless and until there are contraindications for succinylcholine. So let us see the properties of succinylcholine. Remember, it is a depolarizing neuromuscular blocker, which means it's going to act like acetylcholine and they're going to cause exaggerated contractions in the muscle by acting on the postsynaptic terminal NM type of acetylcholine receptors, and they cause paralysis by fatigue, which means after giving a succinylcholine, you can see a lot of fasciculations happening everywhere in the body. Clear? So what is the dose of succinylcholine? It is approximately 1.5 milligram per kilogram, and the onset is very, very fast. It's going to act within 45 to 60 seconds. At the same time, the duration is also faster. It's going to end up very fast as well, which is going to act only for a short duration of 6 to 10 minutes, which means it's a very, very ideal RSI drug. Clear? So what are the side effects of succinylcholine? I told you it's the choice neuromuscular blocker for any RSI except in a patient who's having contraindication of succinylcholine. That's it. So what are the side effects? You can get hyperkalemia. They can cause raised intraocular pressure. They can also produce malignant hyperthermia. They can also produce bradycardia, but remember, because they are acting like acetylcholine, sometimes they can act on the heart and they can produce bradycardia. Remember, this usually happens only with repeat dosing. So only if you keep giving the doses again and again and again. So then only you will result in bradycardia. Otherwise, you are not going to result in bradycardia at all. So these are some of the complications of using a succinylcholine. Clear? But that also will lead to certain contraindications. So this is a very, very important question. Contraindications for succinylcholine is really important. So remember, any condition that predisposed to hyperkalemia, which means hyperkalemia itself is a contraindication, and conditions that predispose to hyperkalemia is also a contraindication. For example, many muscular conditions will be the contraindication. So if, for example, if the patient is having rhabdomyolysis, so remember, succinylcholine in rare instances can also result in rhabdomyolysis as well. So that is a different story, leave them. So rhabdomyolysis is a definite contraindication, there is no doubt about that. If a patient is having a neuromuscular disease, for example, amyotrophic lateral sclerosis, denervation syndromes, muscular dystrophies, then if the patient is having multiple sclerosis, all these things are neuromuscular diseases, and these are contraindications for the use of succinylcholine. And next, if the patient is having ischemic stroke or any form of paralysis and immobilization that is more than 72 hours old and within the last 6 months is a contraindication for succinylcholine. Similarly, burns that are more than 72 hours old and within 6 months of age, definite contraindication. This is very true, especially if the burns is involving a total body surface area of more than 10%. Definitely. All these are important contraindications for the use of succinylcholine. And obviously, crush injuries. Even in crush injuries, you are not going to use succinylcholine, especially if they are more than 72 hours old and less than 6 months. Definitely are not going to use succinylcholine. So these are some of the contraindications. First is always the hyperkalemia and conditions that predispose to development of hyperkalemia. Remember, succinylcholine is not a contraindication, but you have to use with a lot of caution, which means you have to be very cautious in patients who are having AK and CKD, who are also prone for development of hyperkalemia very fast. Fine. Second contraindication, if the patient is suffering from a malignant hyperthermia or a history of malignant hyperthermia. You know, malignant hyperthermia is due to mutation of the ryanodine receptors in the sarcoplasmic reticulum. At the same time, the treatment of choice for malignant hyperthermia is going to be dantrolene sodium. So these are some of the core pharmacology and anesthesia concepts. At the same time, I told you succinylcholine is going to cause raised IOP. So which means in penetrating globe injuries, you cannot use succinylcholine because they can cause raised intraocular pressure. That's the reason. So these are some of the contraindications for the usage of succinylcholine. Fine. Next neuromuscular blocker is going to be the ROC, that is rocuronium. Remember, rocuronium is a non-depolarizing neuromuscular blocker, which means it's going to block the NM type of acetylcholine receptors. Rather than overacting on them, they block the NM type of acetylcholine receptors and they are going to cause paralysis of the muscle. Remember, since succinylcholine acts like acetylcholine and patients with myasthenia gravis may not respond to acetylcholine properly, because of that they may not respond to succinylcholine also properly, because there will be antibodies that are occupying the acetylcholine receptors already, which means you need a higher dose of acetylcholine. Similarly, you need a higher dose of succinylcholine to displace these antibodies and cause reaction in the postsynaptic area. Because of that, in patients with myasthenia gravis, you might be needing a higher dose of 2 to 2.5 milligram per kilogram as well, which means the dose needed to be increased in patients with myasthenia gravis. Whereas, what is the dose of rocuronium? Rocuronium standard dose is approximately 1 milligram per kilogram, but remember, the dose needed in myasthenia gravis is actually less, because these are actually blocking the NM type of acetylcholine receptors, which is the same thing that is done by the antibodies in myasthenia gravis. That's why. So onset of action little slow, but still manageable, 60 to 75 seconds. But the duration is what the problem is, because it's going to be acting for 40 to 60 minutes. You know, like suppose if you introduce this agent and if you cannot intubate the patient, it's going to be, you know, like a mess there. So the anesthetist or critical care physician or emergency medicine practitioner is going to be in a soup. So it's very, very, very difficult to reverse this agent. You have to bag for 40 to 60 minutes, which is a very, very painful job. So that is the reason why they have found out an antidote for it. So reversal agent for it. So if they ask you what is the reversal agent for it, answer is Sogamadex. Sogamadex is a reversal agent for any non-depolarizing neuromuscular blocker, especially for rocuronium, especially in emergency scenarios like RSI, which is given IV, and the dose of Sagamedex is 16 milligram per kilogram, and the side effects of Sagamedex, bradycardia, and sometimes fatal anaphylaxis also. Remember, you use rocuronium only in patients who are having contraindications to succinylcholine. Otherwise, you're not going to use this rocuronium at all. So then next question they will be asking is, how will you assess the neuromuscular tone? What is the standard area which is an indicator for the muscular tone when you are giving a muscle relaxant like a succinylcholine or a rocuronium? So answer will be masseter tone. Masseter tone is the gold standard. That is where we assess the activity of the neuromuscular blocker, especially by looking at the laxity of the jaw. Clear? So the jaw, if the neuromuscular blocker action is complete, the jaw will start moving freely. Clear? So masseter tone, this is the best site for assessing the neuromuscular tone. And again, it's one of the first sites to be affected by the neuromuscular blocker as well. That's why. And even for reversal also, this is the first area we generally look for. Okay. Now we have finished this T0, that is paralysis and induction. So now we are moving on to the next one, that is positioning. Sixth P, that is positioning. So usually we do the positioning at T plus 30 seconds, T plus 30 seconds, that is positioning. We know for intubation, we have to keep the patient in either sniffing position or a ramped up position if the patient is severely obese. Remember, ramped up position we follow only if the patient is in severe obesity. We have discussed in detail about the positioning aspects in the previous video itself, so I'm not going to tell much. So now we have positioned the patient. The next step is placement with proof. So this is the sixth P, penultimate P, that is tube placement. That is placement with proof. And that proof is really important. This is the sixth P. So tube placement, the techniques, like direct laryngoscopy, video, fiber optic, everything we have covered in the previous video itself. So right now, I'm just going to talk about the proof. So remember, the gold standard is always waveform capnography. But remember, even waveform capnography has some pitfalls. For example, if a patient is in a cardiac arrest, the curve will be flat only. In those settings, you don't know whether the patient is having esophageal intubation or a tracheal intubation for sure. So that is the reason why we have devised a lot of other things to find out whether the tube is in the trachea or the esophagus. So let us see. So how waveform capnography is going to help. So remember, so patient is not in cardiac arrest. The patient is not in cardiac arrest. You can feel the pulse. You can see the monitor. The saturation is on. The pulse is on. In this condition, waveform capnography is definitely the gold standard. So if the tube is in the trachea, your waveform should be something like this for sure. So this is the normal waveform. If you don't get this, definitely the tube is not in the trachea. Suppose if the tube is in the esophagus, what will you get? You might get some initial waveforms like this, but over time it will, because of the esophageal and stomach fundic carbon dioxide that usually tends to accumulate. So you might get initial small waveforms like this, but usually there will be less than 6 waveforms. Eventually it will end up with a flat line. So this is for sure the tube is in the esophagus. But the problem is, what if the patient is in cardiac arrest? The curve is definitely going to be flat. The ETCO2 curve is definitely going to be flat if the patient is in cardiac arrest. So you can't really tell whether the tube is in the trachea or the esophagus in a patient who is going to have a flat line because of the cardiac arrest. Clear? So that is the reason why we can use some alternative methods in this condition to confirm whether the tube is in the trachea or the esophagus. But these methods are not very good. But at the same time, at least you have some techniques. That's all. So first one is the aspiration technique. So what do you mean by aspiration technique? Which means when you take a big syringe, a 50 ml syringe for that matters, and if you connect it to the ET tube and if you aspirate, definitely if it's in the trachea, the negative pressure will be counteracted by the air that is coming in from the trachea and the lungs, so that the syringe will be filling with air without any resistance at all. And trachea also will not collapse because it's made of cartilage. Supposedly, if the tube is in the esophagus and if you aspirate, within 5 to 6 ml of aspiration of air, you will find a lot of resistance and the plunger cannot be withdrawn any further, because the moment you create a negative pressure with the syringe by taking the plunger towards you, the smooth esophageal smooth muscles will collapse, and definitely it will prevent any further movement of air into your syringe. So that's one way. Second, the similar principle can be applied in certain devices called esophageal detector devices. Again, they work by similar principle. You have a balloon-like device, you compress it. It's like a small balloon-like ambu-like structure. So it's a self-recoiling structure. It's like a balloon. So you compress it and you put it in the tracheal line. So when you release the balloon, if it's in the trachea, definitely it will re-expand very fast because the air is going to fill into the balloon. Suppose if it doesn't fill into the device, and if you press and if you leave it and still it remains compressed and it's not getting its expansion at all, means definitely it's in the esophagus, because the collapsing smooth muscles of the esophagus will not allow the balloon to expand at all. This is esophageal detector device. Clear? So let us see this video. So what is going to happen with this aspiration technique and this esophageal detector devices? So what you are seeing this person is doing here is, he is taking the syringe and is trying to aspirate from the trachea. Definitely if it's in the trachea, it should be without any resistance. Similarly, if you put the balloon in the compressed manner, it will re-expand immediately if it's in the trachea, for sure. So, but this is in demonstration. If it's in the esophagus, the smooth muscles of the esophagus will not allow the balloon to expand at all. So the balloon will be something like this and it will not expand. So this is the esophageal detector device and the aspiration technique. So simple. And number 3, now ultrasound is also coming. Ultrasound is emerging as one of the very powerful tools in these scenarios. So how you can use? You are going to use the tracheal ultrasound. So you have to demonstrate it. So let me show how tracheal ultrasound will work. So let us see this video. So in this video, you can see the first arrow is the esophagus and the second arrow is the trachea. The big one is the trachea and the small circular structure is the esophagus. And you can see the tracheal rings here. And you can see some white glistening structure also here. That is the air that is present in the trachea. Now, if the patient is having esophageal intubation, you will start seeing 2 tracheas here. So you can see 2 tracheas here because the patient is having esophageal intubation, and the esophagus is now, you can see it's starting to increase in size, and you can see 2 structures that are similar to the trachea, which should not happen at all. So one more time, you can see this is the esophagus and this is the trachea, and you can see once the esophageal intubation happens, now the esophagus also looks similar to that of the trachea, isn't it? So now if you are doing a tracheal intubation for that matters, so you can see only the trachea will expand and the esophagus will not expand at all. You can see very clearly. Once the trachea will start having the movement and the esophagus will still be the same size. Clear? So this is very, very simple, straightforward, easy method to tell that the patient is having tracheal intubation or esophageal intubation. So clear? So very, very simple. So ultrasound is fast, very accurate, and it's supposed to be 97 to 100% specific for esophageal intubation. If you have an ultrasound, please use ultrasound. Fine. So there are some other techniques also, like you can use a flexible intubation scope. It is like a bronchoscope only. So if you go into the endotracheal tube and if you go deeper and you have to see the tracheal rings and the carina. If you're not able to see that, likely it is in the esophagus, that's all. So this is another technique, flexible intubation scope. chest X-ray. Remember, chest X-ray will not confirm where the tube is in the trachea or in the esophagus. It will just tell you after tracheal intubation, the depth of insertion can be assessed by using a chest X-ray. Fine. So that's the idea of a chest X-ray, because chest X-ray for confirmation of the tube, whether it's in the trachea or the esophagus, for this sake it is highly unreliable. You cannot use this. Clear? So this is the these are the techniques that you can use, especially when the curve is flat because of the cardiac arrest. So in this condition, you have to use some alternative technique to find out whether the tube is in the trachea or the esophagus, because waveform capnography in this condition may not be fully reliable. Fine. So now you have placed the tube and you have confirmed that the tube is in the trachea. Fine. Placement with proof is over. Now finally, the 7th P, that is post-intubation management. Post-intubation management. So this is the final 7th P. So what do you mean by post-intubation management? So first is disposition. You have to shift the patient to ICU if the patient is not already in ICU. Second, whether to do a mechanical ventilation or whether to just connect to a CPAP machine or whatever. So it's all up to the clinician and depends on the patient factors as well. And what are the drugs to give, sedations, whether to continue or not. Usually we don't continue any sedation we use for induction. We continue sedation like fentanyl or probably dexmedetomidine. These are the sedation agents we continue after intubation. So all these decisions has to be made in the post-intubation period only. And at the same time, you also have to decide on post-intubation hemodynamic instability and hypoxemia. These are the two things you have to keep in mind. Post-intubation hemodynamic instability can be of two types. One is called a post-intubation hypoxemia. And second one is post-intubation hypotension, or otherwise referred to as a post-RSI hypotension. What are the reasons for post-intubation hypotension? Remember, the first reason could be increased intrathoracic pressure. Usually this increased intrathoracic pressure is due to too much of positive pressure ventilation. For example, you have lungs and you have heart like this, right, in the mediastinum. So when you are inflating the lungs with too much of positive pressure, so they are going to expand too much. Because of the too much of expansion, they might result in compression of the heart and creates an artificial tamponade-like effect on the heart, which might cause an obstructive type of shock and the obstruction to cardiac flow, and that itself might result in hypotension. So what is the intervention you are going to do? In this condition, please avoid forceful bagging. That is forceful bag ventilation, a bag valve mask. That is forceful bagging should be avoided. If you do too much aggressive or over enthusiastic bagging, this might be the case. So avoid that. Number two, it could be induction agent related. We have used a lot of induction agents during anesthesia, isn't it? So this could be a result of induction agent related hypotension. For example, except etomiprate and ketamine, your propofol, thiopental, midazolam, all these agents can be associated with hypotension. You have to be careful about that. So usually induction agent related hypotension will be very, very transient, and treatment wise, you can use a bolus of IV fluid like normal saline, plus or minus you can give a push dose vasopressor. Now this push dose vasopressor is emerging as a very, very important therapy in pre-intubation optimization also, as well as in the managing post-RSI hypotension as well. So usually push dose vasopressor, we use classically phenylephrine, which is a pure alpha-1 agonist and a full vasopressor at a dose of 100 microgram, or you can use a epinephrine, a single dose of 10 microgram. So this is a standard dose of push dose vasopressor. Remember this point only. So they are emerging as a very important treatment for post-RSI hypotension. Number three, it could be due to ongoing fluid loss. Ongoing fluid or blood loss is like hypovolemic shock only. So obviously you are going to manage with IV fluids like normal saline, which is more than enough. Colloids are unnecessary here. Usually for resuscitating hypovolemic shock, either use blood or use a IV fluid like normal saline. It could be due to cardiogenic shock as well. So if the patient's hypotension is due to cardiogenic shock, so you can avoid this hypotension due to cardiogenic shock by taking some pre-intubation pre-optimization. Like for example, you can use etomirid. I told you etomirid is the best induction agent in the presence of cardiogenic shock. So use etomirid for RSI. At the same time, use a BPAP. Just try to open up the alveoli a little bit prior to RSI. Prior to RSI, even consider a push dose vasopressor, plus or minus a push dose vasopressor prior to RSI. At the same time, after RSI, if the patient still ends up with hypotension, try to reduce the PEEP. So this is the treatment, actual treatment of post-RSI hypotension. So try to reduce the PEEP because it might be creating a tamponade effect on the heart by causing hyperinflation of the lungs. Plus or minus, you can consider norepinephrine, which can act as both vasopressor. At the same time, it can act as a inotropic agent as well. So best is always norepinephrine. So you can use that. Fine. So suppose if you are having post-RSI hypotension due to obstructive shock, don't worry about all these types of shock. We have a separate segment on shock. We're going to discuss later on in cardiology. But right now, trust me and just understand these types of shock. Obstructive shock means obstruction to blood flow. It could be due to pulmonary embolism, or it could be due to tension pneumothorax, or it could be due to cardiac tamponade. So treatment of the underlying cause is the most important thing. So suppose if you are ending up with a tension pneumothorax due to barotrauma, then put a wide bore needle in either the second intercostal space or the fifth intercostal space on the involved area and try to take out the air first, and later on followed by a definitive chest drain to completely resolve the tension pneumothorax. If it's cardiac tamponade, try to take out the fluid around the heart by doing a pericardiocentesis. Suppose if you are having a pulmonary embolism, try to take the embolus out either by giving a thrombolysis or a thrombectomy, catheter-mediated thrombectomy also. So it all depends. Treatment of the underlying cause is of paramount importance in treating an obstructive shock. But more than that, you can optimize the patients with IV fluids plus or minus norepinephrine in these patients as well. You can add a ketamine if you want. For RSI, instead of using a etomirid or any other drug, you can prefer ketamine in this case, because first choice preferential drug of choice in a patient with shock is always ketamine, except cardiogenic shock where you use etomirid as the choice. So you can use ketamine. Okay. Then you have distributive shock. So distributive shock can be due to neurogenic shock, maybe due to anaphylactic shock, or more commonly due to septic shock. So what you can do here, and again post-RSI hypotension due to distributive shock is best treated with IV fluid plus or minus norepinephrine, ketamine for RSI, and you can even consider push dose vasopressor. Clear? So this is how you optimize a distributive shock. Remember, again, ketamine is the choice for patients with distributive shock. But remember, instead of norepinephrine, you can consider epinephrine if the patient is having anaphylactic shock. This is a no-brainer. These are small concepts but very powerful ones. Anaphylaxis means epinephrine only. For all the other purpose of distributive shock, you are going to prefer norepinephrine only. Fine. So these are the various optimization strategies in a patient who is going to go for post-intubation hypotension. So what about post-intubation or post-RSI hypoxemia? How we are going to optimize these patients? The first one, the reason we want to know is EDT malpositioning. So the endotracheal tube can be malpositioned. So it can be due to two reasons. Either the tube is in the esophagus or the tube is in the very deep. So mainstem intubation or right endobronchial intubation. So it's very simple. So identification, diagnosis of this esophageal intubation usually by capnography. Capno is the gold standard for this, except if the patient is not in cardiac arrest. What will be the treatment? Re-intubate the patient. You take the tube out, there is no other option, you have to re-intubate. Mainstem intubation is very simple. You are going to diagnose clinically. This is the most important concept. So chest X-ray is the definitive one. Chest X-ray is the best and definitive one for confirming mainstem intubation after you confirmed with capnography. Remember, first of all, you have to confirm the placement in the trachea and in the respiratory tract using capnography. Then the depth can be assessed with the help of chest X-ray. So straight away, chest X-ray cannot differentiate between the esophageal versus tracheal intubation. So it should not be used as a primary investigation. So, but for confirming the depth of endotracheal tube, after the confirming the placement in the trachea, your chest X-ray is the best. Okay. But clinically, you have to assess because the patient is going to rapidly desaturate. So clinically, first you have to assess the patient. Clinically, you know, whenever you have intubated on the right bronchus, means it's a mainstem intubation and it's an endobronchial intubation. Only the right side chest will start expanding and you'll have an asymmetric chest raise. Left side is not going to expand. And only you are going to hear the breath sounds on the right side. Left side, you're not going to have any breath sounds at all, especially when you're auscultating in the axilla. So this asymmetry will tell you you're probably having a right endobronchial intubation. So in this condition, no need to take the tube out completely. Just adjust the tube and pull the tube out a little bit and the patient will be all right. Adjust the tube. Okay. Number 2, if you have cuff leak, your endotracheal cuff is leaking. You're having a cuff leak. Diagnosis is very simple. Identification, you will have no pressure in the pilot balloon. Loss of pressure in the pilot balloon. So this is a easy identification. So which means whenever you don't have the cuff inflated properly, which means there will be a leak of the positive pressure. You cannot maintain the positive pressure below that. So you cannot give positive pressure ventilation at all. If the patient is having a shunt, the alveoli will not open, so hypoxemia will worsen or it will continue to happen. So you have to change the cuff, which means you have to change the ET tube only. There is no other option. Clear? Third one, there could be mucus plugging. Identification of this mucus plugging is quite simple. If you connect to the ventilator, you will be finding very high peak inspiratory pressures due to obstruction. We'll see that in the ventilator section in detail. At the same time, you will be having high resistance to bagging. When you are doing a bag valve mask ventilation, when you are doing a bagging with an ambu bag, you will have a very, very high resistance. You will not be able to, bag properly and your hands will start paining. So the ideal way of treating this patient is only by doing a bronchoscopy and removing that mucus plug that is obstructing the regions, or suction it properly at least. If it's very proximal, you can remove it by suction itself. Fine. Number 4, tension pneumothorax. We know how to treat that. We have seen multiple times. I'm not going to discuss again. That is due to barotrauma. Then malfunctioning of the oxygen apparatus. Oxygen apparatus malfunctioning. Again, this is an equipment problem, so you have to change the equipment. Finally, patients are going for rapid desaturation. Remember, whenever the patient goes for rapid desaturation, immediately after an RSI, think about inadequate pre-oxygenation. Inadequate pre-oxygenation. Either the examiner, who's seeing has to suspect this inadequate pre-oxygenation, or it could be the patient themselves who might have inadequate pre-oxygenation, how much ever you do. There are certain patients who's going to desaturate invariably, even if you pre-oxygenate very nicely. Who are those set of patients? These are the patients where you have an extremely reduced time to desaturation. Remember, the normal time to desaturation is approximately 8 to 10 minutes in a very healthy adult. But certain group of patients might desaturate very, very fast within 3 minutes. Who are those? Number 1, people who are having morbid obesity. Second, people who are having restrictive lung disease. Third, people who are having third trimester of pregnancy. Fourth, people who are having shunt formation like ARDS. Why? Because here the FRC itself will be very low in these conditions because there will be alveolar collapse and the compliance of the lungs and the chest wall will be very poor in restrictive lung disease. Because of that, even if their FRC itself will be very small. So how much ever you pre-oxygenate, you cannot expand that FRC in these situations. So that is the reason why they desaturate very, very, very fast. For that matter, even children, because a small chest will usually desaturate within 4 to 5 minutes, even if you do a good pre-oxygenation before intubation. So you have to keep in mind that these patients are having very short time. So which means you have to intubate very fast, otherwise they are going to desaturate. These are unlike normal patients and they're going to rapidly desaturate. So you have to understand this concept again. So these are the causes of post-RSI hypoxemia and post-RSI hypotension as well. Clear? So we have discussed all the 7 P's here. The first P being preparation, second P being pre-oxygenation, third P is pre-meds and pre-intubation optimization, fourth P is the time zero, that is paralysis with induction, fifth P is the positioning, sixth P is the placement with proof, and seventh P is the post-intubation management. Clear? So these are the 7 P's of rapid sequence intubation. I hope you have understood all the 7 P's of rapid sequence intubation. I will also tell you some sample charts of how to fill. So usually this is the chart I generally tend to give it to my juniors and ask them to fill every time. So these are the 4 important charts. Let us see. First is the preparation. Again, in a standard RSI, this is RSI by default. So what you're going to do for a patient. So standard preparation, there is no extravagant preparation here. Oxygenation 3 minutes or at least 8 vital breaths equivalent to 8 vital capacity breaths. And pre-meds usually nil. We don't give any pre-meds for a standard RSI. Induction and paralysis, we are going to use etomidate 20 mg IV and succinylcholine 100 mg IV. Standard RSI, usual standard dose. Positioning, yes, standard sniffing position. Placement, yes, there's no special precautions. We can use a direct laryngoscopy. Usually there's no standard placement precautions, and obviously we have to look for the proof by doing a waveform capnography. Post-RSI management, again regular and standard. There's no much post-RSI management here, miscellaneous nil. So very simple. So this is what a standard RSI protocol is. But there are some special population like raised ICP. What is the RSI here? Preparation wise, again standard preparation. There's not much preparation here. Pre-oxygenation same. You're going to use 3 minutes of 100% O2, or volume of oxygen that should be given must be equal to 8 vital capacity breaths. Pre-meds, yes, we are going to use lignocaine 100 mg IV. Clear? Lignocaine 100 mg IV. Sure. Induction paralysis, yes, you can use etomidate 20 mg. Same, there is no special thing here to consider. At the same time, I am going to give succinylcholine 100 mg IV. Remember, make sure one thing here, ketamine is absolutely contraindicated. You cannot use ketamine here. Remember, you can add fentanyl if you want. Fentanyl plus or minus fentanyl 200 microgram IV. If you want, you can add fentanyl. No problem. But lignocaine itself is sufficient most of the time. If you want, you can add fentanyl as well. Positioning, again, if you suspect a cervical spine injury, you have to be very careful. But apart from that, it's a standard positioning. Placement, again, through direct laryngoscopy, no doubt. And you see a proof, which is standard, it is EtCO2. Post-RSI treatment, yes, you can give a therapeutic hyperventilation. Once you connect to the ventilator, you can start with therapeutic hyperventilation. In the sense, you have to maintain the PaCO2 in the range of 30 to 35 millimeters of mercury. Fine. But remember, less than 30 is very dangerous. I told you less than 30 should be avoided because it can result in severe cerebral hypoperfusion and itself becomes deleterious to the brain. And global hypoperfusion may result even in brain death. So don't do that. So 30 to 35 is the standard. Miscellaneous, again, raised ICP care. So which you can see later on in the CNS section, how to manage a raised ICP due to traumatic brain injury. Okay, RSI in a patient with a reactive airways disease, how you're going to manage. So in a patient who's having a reactive airways disease, again, preparation is standard. There's no doubt about that. And pre-oxygenation, same 3 minutes or 8 vital capacity breaths. And pre-meds, yes, you can use lignocaine here, 100 mg IV. And induction usually done with ketamine. Lignocaine is optional, not mandatory. Ketamine will give 100 milligram IV followed by succinylcholine 100 milligram IV. Remember, I told you ketamine has bronchodilator properties. That is why in reactive airways disease, we prefer using a ketamine. Positioning, again standard positioning, there's no significant change. Placement, again standard placement, proof by EtCO2. And post RSI treatment, you can consider giving bronchodilators as well, like nebulizations and all. But remember, one thing you have to note after intubating is the high peak inspiratory pressures. Whenever you have a high peak inspiratory pressure means there is bronchoconstriction and the patient has to be treated with bronchodilators, and you have to bring back the this peak inspiratory pressure back to normal. Usually a high PIP with a normal plateau pressure usually indicates high airway resistance. Fine. Miscellaneous, nothing. Again, same standard management. You are going to treat how you are going to treat other patients. That's all. But with the addition of bronchodilators. What is the RSI pediatric? So pediatric patient, especially if they are less than 10 years of age, what are you going to do? Preparation, again a standard preparation. Remember, positioning wise, you don't need the standard sniffing portion. You need not keep that. You just keep the pediatric patient's head without anything, and you have to ask the assistant to hold their heads because of the large floppy heads. We have discussed in the previous video itself. So pre-oxygenation, again 3 minutes standard or 8 vital capacity breaths. Pre-medications, yes, you can use atropine if you want. Standard dose is 0.02 milligram per kilogram IV. Typically, we give 0.3 to 0.6 milligram, that is half cc to 1 cc of atropine. Induction, etomidate 0.3 milligram per kilogram and followed by succinylcholine 1.5 milligram per kilogram. And positioning, remember, no need of sniffing portion. That is very, very important. No need of sniffing portion in a pediatric individual unless and otherwise specified. Placement, again standard placement, use a Miller's blade here if possible, followed by confirmation with EtCO2. And post RSI treatment, nothing special, standard, and no miscellaneous treatment as well. So these are the pediatric chart. So it's better always to consider charts like this to understand what are the differences in the RSI and what are the different drugs that you are going to use in different set of patients. But remember, like this, you can create your own chart for septic patients also. So I'll give you as a homework. So you can do the same chart and how will you do in a sepsis and septic shock, how you're going to do RSI in a cardiogenic shock patient, how you're going to do an RSI in a hypovolemic shock patient, and you can do your own charts as well. So like this, you create your chart, and many times if you want to practice also, these charts will be extremely helpful. Clear? So with this, I think we can finish the RSI, rapid sequence intubation, and we'll wind it up and we'll move on to the next topic, that is waveform capnography.